So my topic for today is decompressive craniectomy, benefit or social problems. I'm Professor Rudin Dome from the Faculty of Medicine, University of Medicine, Tirana, Albania. Uh, I really congratulate to you for organizing this symposium, and many thanks to Professor Yasmina Smajic and organizing committee for inviting me. It is always my pleasure being with you in your symposium or conferences. Nothing to declare regarding my conflict of interest with the topic, and as you know, Balkan Anesthesia Platform is an organization and collaboration between the Balkan Societies of Anesthesia and Intensive Care, who took place for the first time in Antalya in TARC Congress, in TARC Congress, and we are improving our collaboration, of course, between our countries. These are original views from my hospital, a patient who underwent to decompressive craniectomy in order to treat increased intracranial pressure refractory to standard and conservative therapy. These are photos that demonstrating all the videos that you see, that you saw that a part of skull is missing, and as you can see, is catastrophic intracranial increased intracranial pressure with derivation of or the shifts of median structure, and as a result, the neurosurgeons decide to perform decompressive craniectomy. Regarding general consideration, as everybody knows, increased ICP is of main concern in traumatic brain injury patient management. Of course, can be as a result of traumatic brain injury, but can also be due to bleeding, edema, and hydrocephalus. And increased ICP is very often associated with shifts towards median structures, increasing brain ischemia, inducing brain herniation or death, and of course DC. So decompressive craniectomy is reserved in cases of increased ICP refractory to conventional treatments. These are the guidelines from Brain Trauma Foundation that probably state that the two randomized controlled trials like DECRA and the Rescue ICP would provide clarity or whether or not this is decompressive craniectomy is a procedure that can be considered or not, and the neurosurgeon should perform or not amongst other therapeutic options available for severe traumatic brain injury. What are the indications of decompressive craniectomy? So there are many papers like this interesting paper published in Stroke in 2021, decompressive hemicraniectomy for large hemispheric strokes. The paper summarized all the indications and the predictive signs for the development of malignant cerebral edema after hemispheric infarct. The guidelines from American Association of Neurological Surgeons state that candidates for surgical treatments are young patient less than 50 years of age with bleeding location that can be removed by surgical point of view, or for whom surgeries may lower issue or bleeding, edema, and necrosis. But of course, in the surgical treatments, they included craniectomy and craniotomy to remove a part of skull bone, and of course to remove debridement or to do debridement of ischemia and necrosis of cerebral tissue and bleeding and clots also. According to Weill Cornell Brain and Spine Center, they can they summarized two kinds of surgery: surgery for intracerebral bleeding in order to remove the clots and the bleeding, and decompressive surgery that probably relieves pressure on brain and allows the neurosurgeon to remove the pooled blood and repair damaged blood vessels. What about DECRA? DECRA is decompressive craniotomy randomized controlled trial study which enrolled 155 adults under 60 years old with an ICP refractory to increased ICP refractory to conventional treatments after traumatic brain injury, 22 hours after the admission, and neither hypothermia and barbiturates were used. The ICP thresholds for enrolled the patient in the study is an increased ICP over 20 millimeters of mercury scale. And they performed a comparison or compared befrontotemporal parietal DC, so decompressive craniotomy, to conventional treatment. This study, published in Current Trauma Reports in 2018, can of course summarize all the data of the patient, but as you can see, the death rate it's approximately let's say the same, but of course vegetative state was very high in decompressive craniotomy than in standard patient. The paper, published in Journal of Neurotrauma in 2020, entitled Patient Outcomes at 12 months after early decompressive craniotomy for diffuse traumatic brain injury in the randomized DECRA clinical trial, compared DECRA and the rescue ICP, but both trials found that decompressive craniotomy did not improve functional outcomes at 12 months when independent functional outcomes were defined as scored 5 till 8 on the extended let's say Glasgow scale. Both trials were also found that decompressive craniotomy increases vegetative outcomes in survivors at this time, so at 12 months after the traumatic brain injury. Rescue ICP trial, it's a very interesting trial, randomized control trial also, who enrolled 408 patients with an increased ICP more than 25 millimeters of mercury refractory to the standard treatment for 1 hour till 12 hours. The patients were enrolled during the years 2004 to 2014, undergoing lateral or bifrontal decompressive craniotomy, and outcomes were measured after 6 and 12 months were also recorded. Decompressive craniotomy decreases ICP, but increases a race of functional disabilities and vegetative states. That was the conclusion founded by the authors and the collaborators of Rescue ICP trial. In June 2022, the paper published in JAMA, Journal of American Medical Association, entitled Evaluation of Outcomes Among Patients with Traumatic Intracranial Hypertension Treated with Decompressive Craniotomy as a Standard Medical Care at 24 months after the traumatic brain injury. the authors concluded that, of course, we have a marked reduction of increased intracranial pressure, but higher rates of vegetative state, severe disability, and moderate disability. That's pretty the same like Brain Trauma Foundation Traumatic Brain Injury Guidelines has stated in 2020. So, decompressive craniotomy can reduce intracranial pressure, ICP, but prognosis of disability and vegetative state are, of course, uncertain. This article, published in Current Opinion of Anesthesiology, uh, declares or recommends that probably there are so we can reduce ICP, but we cannot long term, let's say, improve the patient prognosis and relieve their disabilities toward the normal life. So it's a matter of debate. We have to do decompressive craniotomy in order to, let's say, to decrease intracranial pressure and probably to have a patient with a disability or not. So the family members or the proxy decision maker familiar with the patient values may be part of the team that it's going to have that decision to perform or not decompressive craniotomy in order to explain to the familiar or the relatives of the patient all in details all the let's say outcomes features of the patient in 12 months after the decompressive craniotomy or let's say more than 2 years. The paper published in 2023, Decompressive Craniotomy versus Craniotomy for Acute Subdural Hematoma, published in New England Journal of Medicine, enrolled more than 200 patients on craniotomy and more than 200 patients on decompressive craniotomy. The primary outcome was the rating of extended Glasgow outcome scale at 8-point scale, ranging from death to upper good recovery at 12 months. And they found that death was 30.2% in the patient of in the craniotomy patient and 32.2% of the cranectomy group, and vegetative state occurred in respectively in 2.3 and 2.8%, and wood complications occur 3.9% of the craniotomy group and 12.2% in the craniotomy group. But of course, the Glasgow outcome, extended Glasgow outcomes scale was, let's say, pretty much the same. And you can see in the slide summarize the data of this study, comparing decompressive craniotomy with craniotomy for acute subdural hematoma. So in my hospital, there are this original data from 2020 till 2023. So we performed 7 patients. We performed in 7 patients decompressive craniotomy, largely, so mainly for occlusions of cerebral artery, media cerebral artery, or large infarction, or subarachnoidal bleeding, fissure 4, and so far. And we have among these patients 3 patients were dead, and 4 patients discharged in home, but we have no further data after this period. But the first one, that was a Canadian man. He was operating. So it was suggested by the colleagues from neurosurgeons from Canada to perform decompressive craniotomy, and was done. And he was absolutely going good without any disability after he was discharged in OWARD, and after that in home. But of course, there are few data, so we cannot recommend something more than two well-known randomized trials like DECRA and Rescue ICP. These are original photos of a case that we have performed decompressive cranioectomy, the last one that was, let's say, 2 or 3 months before my presentation. And as a conclusion, decompressive cranioectomy is considered the last maneuver to reduce refractory intracranial pressure, lowers intracranial pressure, but increases the vegetative state, and physicians must explain in details to the relatives when the decompressive craniotomy is considered to be done in their in their relative, that it's of course a matter of discussion. But this is a very interesting story, because you we must say that probably it's a matter of course, it's a matter of culture, of the point of view of the life, and how we want to have our lives, to have with disability, or let's say, to have a good life without disability. So thank you very much, and of course I really appreciate the invitation, and I have many greetings to all of you, and I wish you a good symposium, a good congress. Thank you very much.